Hello, everyone. My name is Sridurga Mithraprabhu, and I'm a research fellow at the Australian Centre for Blood Diseases based at the Alfred Hospital in Melbourne, Australia. And today I'm going to be presenting our ASH abstract that we presented this year in 2022. And as the title suggests, we looked at circulating cell-free tumor DNA mutations, that is RAS, RAF, and DNA repair gene mutations, and found that it associates with high risk in treatment resistance in primary refractory multiple myeloma. The background to this study was data from the Australian and New Zealand Myeloma and Related Diseases Registry, or MRDR, wherein we analyzed 1,300 myeloma patients who were newly diagnosed and transplant eligible. We found that 23% of this patient population failed standard frontline therapy. And it was impossible to recognize these treatment-resistant patients upfront. This was because the standard RIS classifications did not or failed to identify a substantial proportion of these patients who were treatment resistant. So more genomic studies would help identify these patients and also inform alternative therapeutic strategies that we could employ for patients that fail standard frontline therapy if we knew what mutations they had beforehand. So our hypothesis was to use circulating cell-free tumor DNA from peripheral blood plasma instead of a bone marrow biopsy. And this could provide a more holistic approach to gain an insight into the genomics of high-risk and treatment-resistant patients. The study design was an Australasian Leukemia and Lymphoma Group, or ALLG, MM17 clinical trial. It was a phase 2 multi-center single-arm study of carfilzomib, thalidomide, and dexamethasone, or KTD, in 50 newly diagnosed transplant-eligible myeloma patients who were refractory or registered suboptimal response based on the IMWG criteria to bortezomib, cyclophosphamide, or dexamethasone, or VCD. The way we designed this study was we collected peripheral blood plasma-derived cell-free DNA. So this was the liquid biopsy. And we derived CD138 positive myeloma cells from a single-site bone marrow biopsy. And using this paired sample collected at baseline or study entry, we performed targeted amplicon sequencing for 22 myeloma-relevant genes. So this is an ultra-sensitive technology where it's able to identify single nucleotide variants, deletions, insertions, and frameshift mutations, both in cell-free DNA and myeloma cells. We also performed sequential analysis of cell-free DNA samples at cycle 3, day 1, and at end of study or relapse, whichever occurred earlier. One of the first analyses we did was to identify mutations in baseline. So this was both in bone marrow and circulating tumor DNA. And we identified the mutational spectrum and correlated this to KTD response. And in this slide, I'm showing you only the ctDNA results. We found that the mutational spectrum of ctDNA in relapse patients had a unique mutational spectrum in the sense that there was a higher proportion of mutations in the RAS-RAF or the ATM-ATR-TP53 mutations, which I will refer to as DNA repair mutations. And when we did a chi-square test of the proportion of patients with these mutations, we found that relapse patients had a higher proportion of both RAS-RAF and DNA repair gene mutations. We then utilized this information wherein we identified patients who had RAS-RAF and DNA repair gene mutations and correlated this to progression-free survival on KTD. So the way we demarcated the patients was they were classified as bone marrow positive or ctDNA positive if they had a mutation in these two pathways, or negative if there was no mutational presence in these. And we found that there was no difference between patients who were positive or negative based on the bone marrow analysis. But in ctDNA, we found that patients who had a mutation in RAS, RAF, and ATM-ATR-TP53 in ctDNA had a significantly shorter progression-free survival. We then incorporated the presence of this mutation with the ISS, or the SCI92 profiler risk status. So when we combined the ISS information with the ctDNA information, we found that patients who were in ISS stage 2 and 3 and ctDNA positive had a significantly shorter progression-free survival. And this was the case in the SCI92 profiler as well. Any patients that were classified as SCI92 high risk and had a ctDNA positivity did significantly worse on this trial. We also looked at the kinetics of the circulating tumor DNA mutations after therapy. So this was done at cycle 3, day 1 of therapy. And the way we analyzed this was we identified mutations in cell-free DNA at baseline, and then identified the fold change in this mutation at cycle 3, day 1. So if there was an increase in the mutational burden, it was a positive fold change. A decrease in the mutation was deemed as a negative fold change. And this was then correlated to the best MRD response achieved during this trial. And what we found that was patients who were MRD negative and had a negative fold change. So this was a decrease in the mutational burden at cycle 3, day 1, had a superior outcome on this trial compared to patients who were MRD positive or ctDNA positive or negative. We also looked at the kinetics of how the mutations changed at baseline cycle 3 at day 1 and at relapse. And what we found was that dominant mutations at relapse appear early during therapy. And I've shown you 2 representative examples here, where in patient 2, we had a BRAF and 2 KRAS mutations that were the 3 dominant mutations at relapse. And these 3 mutations were already present at the start of therapy. And in patient 5, we had 2 mutations, ATM and RB1, which were the dominant mutations at relapse, and these were also present at the start of therapy. So to conclude, I want to finish off by saying that circulating tumor DNA analysis is a useful prognostic marker in multiple myeloma. It provides a robust, risk-free, and minimally invasive alternative to bone marrow biopsy. And utilizing ctDNA kinetics can help identify patients who could likely progress on treatment. We also found that some of the dominant mutations that are at relapse are already present early on in the disease, and this opens up opportunities to identify patients upfront who are not likely to respond to therapy, and therefore we could use an alternative therapeutic approach for these patients. And I want to finish off by thanking the entire team that contributed to this study, and funding from the International Myeloma Foundation, the NHMRC, and the Alfred Foundation for making this study possible. Thank you very much.